Good afternoon all. My research is titled A Longitudinal Observational Study on the Effects of Prolonged Use of Anti-Glaucoma Drugs on the Ocular Surface. What is the relation between glaucoma and ocular surface? IOP continues to be the only risk factor which can be treated in glaucoma by medical or surgical means. Anti-glaucoma medications are meant to be used for lifelong and require strict adherence, and the adverse effect hence has to be minimal so that the patient remain compliant and continue the therapy. So what happens if OSD does occur due to anti-glaucoma medications? The compliance will be impaired, there could be treatment failure, there could be progression of the glaucomatous damage, and regarding surgical aspect, there could be long-term conjunctival inflammation causing subconjunctival fibrosis, resulting in failure of filtration surgery, and with both failure of medical and surgical measures, we could be facing the dreaded permanent loss of vision. This is where the study becomes relevant. The purpose of the study is to determine the incidence of ocular surface disease in newly diagnosed cases of primary glaucoma, both open and closed, who have been just initiated on topical IOP lowering therapy. Objectives of the study: the incidence of OSD was analyzed in newly diagnosed patients of glaucoma initiated on topical therapy within the last 3 months. The incidence was compared between those using single drop therapy versus multiple drop, and we studied the association of preservatives used in anti-glaucoma medications and their resultant OSD. This was a longitudinal observation study conducted at Comtesse Charitable Eye Hospital. We recruited 100 eyes of primary glaucoma patients recently diagnosed within the last 3 months, and the time frame was between January 2021 to December 2021. We included patients with primary glaucoma more than 40 years old who have been started on anti-glaucoma medications within the last 3 months. We excluded patients who were less than 40 years and more than 80 years, those with already pre-existing ocular surface disease or using lubricant eye drops in the preceding 3 months, secondary glaucomas, and all the other causes, other causes of dry eye, such as previous ocular surgeries, receiving ocular treatment for causes other than primary glaucoma, contact lens users, lid disorders causing incomplete eye closure, history of conditions resulting in tear film spreading unevenly, such as proptosis pterygium, thyroid eye disease, history of any chemo radiotherapy. Now, after recruiting these patients and getting a detailed medical history, including anti-glaucoma drug usage, we subjected them to an OSDI questionnaire. Then we evaluated them on slit lamp. Then shimmer test and tear film breakup was tested. And then they were stained with fluorescent and lysamine green. And then finally, OSD resultant was graded according to the Dew's grading scheme. This is the OSDI questionnaire, which was developed by Allergan. 3 components are measured, including ocular discomfort, function, and environmental trigger within the last 1 week recall period. The scores that has been obtained was then converted using the formula shown, and then based on the result, they were then finally graded according to normal 0 to 12, mild 13 to 22, moderate 23 to 32, and severe 33 to 100. This is the Dew's dry eye severity grading scheme developed in the International Dry Eye Workshop in 2007. So this is the timeline of our study. After recruiting the patients, there was a first visit was for the recruitment. Then the first follow-up, that is the second visit, was done 3 months after recruitment, and the second follow-up, which is the third visit, was done 6 months after the recruitment. And then data was analyzed. Results and discussion. We found that a staggering 96% of our study population developed OSD by third visit. The role of active drug ingredient, we found that bimatoprost presented a 50% chance of developing OSD, followed by timolol at 32%. We've also found that 13% of patients using timolol did not develop OSD even by third visit. This was generally in agreement with previous studies, such as the studies conducted by Chen et al., who found that increased risk of dry eye was observed for all glaucoma medication, and another study was conducted by Arita et al., who found that meibomian gland loss was found in both prostaglandin-treated eyes as well as in beta-blocker-treated eyes. Regarding preservatives causing OSD, the drugs that we had given to the patient, 60% of patients had benzalkonium chloride, oxychlorocomplex in 24%, and 6% of our patients were using non-preserved drugs. We found that 100% of patients using preserved drugs developed OSD. And we also found an interesting finding is that 8% of patients on preservative-free drug also developed OSD, which we could hint that the active drug ingredient could also be a role in playing OSD, and preservatives may not always be the culprit. This was generally in agreement with previous studies conducted by Pisella et al. As well as by Jenin et al., who both concluded that symptoms and signs are less prevalent when preservative-free drops are used, and that the adverse effects which were caused by the preservatives are reversible after removing the preservatives. We also found that OSD occurred earlier in patients who were on multiple preservatives. They were also found more in patients using multiple drops as compared to single drops. Then increasing incidence was found in single drug users, and the clinical symptoms and signs were progressively worsened by third visit. OSDI score showed a significant value by third visit. And then we conclude that ocular surface disease in the mild to moderate form is a significant problem faced by glaucoma drug patients. And prostaglandin analogs followed by timolol was found to be more associated with OSD. Preservatives was found to be a culprit. Multiple drop was also found to be a culprit. The limitation of our study was that various generic brands were used, so the concentrations of drug and preservatives were non-uniform and equal number of drug was not analyzed. We recommend that routine evaluation of OSD be done in glaucoma patients. We need to limit the exposure of ocular surface to preservatives, and if need arises, we need to resort to surgical measures. When the treatment without prevention is simply unsustainable. And with this, I would like to thank you.
Good study. But
Thank you,
how can you conclude that preservative-free also only 8% has a OSD?
Yes, sir.
On the other hand, other has 100% OSD.
Yes, sir.
So preservative-free is comparatively safe.
It's comparatively safe, but we've always believed that preservative was the first which caused OSD, but we need to now start thinking that the active drug ingredient could also be playing a role in causing OSD.
Okay.
Further study will be required.
What is the maximum follow-up? 3 visit means what is the maximum follow-up?
After recruiting the patient was followed up to 6 months. 3 months from the first and 6 months from the first visit recruitment.
Okay, single drug, 2 drug, 3 drug, what is the comparison?
We've analyzed all sorts of numbers of frequency of drugs, and we found that the single drug users were less likely to have OSD as compared to multiple drug users. Drop users.
Oh, okay.
How do you exclude the pre-existing OSD?
While recruiting the study, actually the analysis of OSD was done at each of these visits. The first visit was a recruitment visit. So during the recruitment visit, if while analyzing the Tierbert or Schirmer or any of these tests, we found a patient was having significant OSD, we excluded them from the study. That is how it was ruled out.